Welcome to part 5 of integumentary. We're going to focus on how to care for pressure injuries. Before I start discussing how to care for pressure injuries, I want to say that preventing pressure injuries on every person should always be our priority. Any patient who is sick enough to be in a facility is at risk for pressure injuries at some point during their stay. So we need to assess all of our patients at least twice a day, assessing their skins and assessing their risk using a tool like the Braden scale. We want to make sure our patients have clean, moisturized skin. If they have moisture issues with their skin, like incontinence, using a skin protectant to create a barrier between the skin and moisture will help. We also want to minimize friction and shear by using proper positioning, turning, and transferring techniques. We want to use appropriate pressure relieving surfaces and ensure proper nutrition. We also want to get these patients moving as quickly as possible, even consulting PT and OT for help. We want to prevent pressure injuries. That should always be our goal every day. Once a pressure injury occurs, it's going to be 10 times harder for us to treat it than it would be if we prevented it in the first place. When it comes to planning and making our outcomes for a patient with a pressure injury, we want to focus on preventing complications. Pressure ulcers can get worse, they can get infected, and they can even cause death. The man in this picture is Superman. It's actor Christopher Reeves. He had a spinal cord injury from being thrown from a horse, and he ended up dying from an infected pressure injury. Pressure ulcers are also very painful, so pain relief is also something we need to focus on. Part of our planning should be to include asking for a consult for wound care, for PT/OT, and for dietary. Wound care will help determine the best treatment for the wound, and PT/OT will help get the patient mobile, hopefully relieving pressure, and dietary will help ensure good nutrition and protein intakes. We also want to make sure that we're preventing pressure injuries from occurring. The most important thing we do as nurses is frequently assess the pressure injuries. Depending on the type of dressing applied and the orders we receive, we may fully assess our wounds twice a day or maybe just once a week. When assessing, we may have to restage our wounds. But just so you know, pressure injuries do not go backwards with staging. We do not downgrade a stage 3 to a stage 2. It will always be a stage 3, but we would start calling it a healing stage 3 if it's healing and starting to look back like a stage 2. But we never go backwards with staging. We have discussed a lot of nursing interventions already, like relieving pressure on pressure sites, using pressure relieving surfaces, improved nutrition, reducing friction and shear, moisturizing dry skin, or using moisture barriers for moist skin, and using pressure relieving surfaces. But there's a lot more we as nurses do to treat these pressure injuries. Nurses clean wounds, we change dressings, and we manage vacuum-assisted wound healing. Overall, there are steps we follow for all dressing changes, regardless of the type of dressing it is. First, we mentally prepare the patient and physically prepare the patient for what we're about to do. This includes pain relief. We pre-medicate for pain, we medicate during the procedure if needed, and medicate after if needed. We gather our supplies, we complete hand hygiene, and we adhere to standard or any transmission-based precautions we need to. Some wounds do get infected with antibiotic-resistant bacteria, and they do get placed in isolation. We then want to remove the old dressing, cleanse the wound, and apply and secure a new dressing. After we remove the old dressing, we need to assess the wound quickly, looking for drainage, odor, and slough. We'll do a more in-depth assessment once the wound is clean. To clean the wound, we can use sterile 0.9% normal saline or a commercial wound cleanser, depending on our orders, to remove any slough or drainage or exudate. We want to clean the wound using a new sterile gauze for each wipe of the wound, cleaning from top to bottom and from the center to the outside of the wound. We use clean gauze for each wipe so we don't contaminate different areas of the wound. Once the wound is clean, we want to dry the wound with clean gauze, the same way we cleanse the wound. Then we want to do more in-depth assessment of the wound, including measurements. If ordered, we can apply a topical treatment that promotes wound healing. Wound healing is called granulation. A little general rule of thumb is how to cleanse the wounds. If the wound is red, we want to protect it. If the wound is yellow, we want to clean it. If the wound is black, we want to debride it. So let's talk about debridement. Debridement is the removal of slough or eschar to promote wound healing. This can be done mechanically, either by surgically removing the slough or eschar, or it can be done using gauze to wipe it away. We can also do chemical debridement using enzymes to dissolve the necrotic tissues, and sometimes we do a combination of both. We can also use certain types of dressings to debride. There is a controversial method of debridement called wet to dry dressings. These used to be used all the time and involved putting wet gauze in the wound, letting it fully dry, and then ripping it out of the wound to mechanically debride the wound. This practice has been found to be cruel and unusual punishment, causing significant pain, bleeding, and damage to the healthy granulation tissue. Wound care nurses will tell you not to do these. If you get an order to do this, you should question it. There are many different types of dressings available to nurses to care for pressure injuries. The most basic, just cover the wound with something until the wound care nurse can tell us what to do type of dressing would be a wet to moist dressing. We wet some sterile 4x4s with sterile saline, we pack the wound, we cover the packing with a sterile dry 8BD pad, and we use some tape. Like I said, it's basic. It's providing moisture and protection while we wait to determine what the best option is. The basic dressing does need to be changed several times a day, so it's not the best dressing to protect the wound because we're removing it many, many times, opening it up to bacteria in the air. When the wound care nurse decides what the most appropriate dressing should be, the nurse is taking into account the amount of drainage and exudate present, how much moisture is present, what the surrounding skin looks like, and how much protection the wound needs. There are dressings that work to absorb moisture and drainage. There are dressings that provide extra cushioning to prevent the wound from more damage. There are dressings that can help protect the surrounding skin from damage. And there are dressings that can help stimulate healthy tissue growth, and some that even control infection. Vacuum-assisted closure, or VAC, is also called negative pressure wound therapy and is a non-invasive device that uses vacuum to apply pressure to the wound bed to absorb large amounts of drainage, decrease bacteria, and stimulate blood supply and healthy tissue growth. This is used for some surgical incisions, but for our purpose today, we're talking about stage 3 and stage 4 pressure injuries. The dressing stays in place for 2 to 3 days, depending on the manufacturer's recommendation, and some wound vacs can even instill antibiotics directly into the wound. These are not usually the first line treatment for wounds, but can be very efficient for large, hard to heal wounds. As long as the dressing keeps a good vacuum seal, these devices are awesome. But if your wound vac is in an area that makes keeping the vacuum seal difficult, these can actually make our jobs much harder. When we evaluate our interventions to see if the wound is healing, we need to do frequent assessments of the wound. The frequency may be dependent on the type of dressing being used, like a wound vac that is changed every couple of days. We're evaluating to make sure the wound has not grown and that there's not more damage, especially to the surrounding tissue. If drainage and exudate has been a problem, we would evaluate to see if the amount has decreased. We evaluate the wound base to see if we have healthy tissue growth. This healthy tissue is called granulation tissue, and it's red, moist, and has almost like a cobblestone road appearance. This is good tissue. This is what we want to see. This means the wound is healing and that what we're doing is working. We also want to evaluate for any signs and symptoms of infection. If the patient's going home or will be doing some of the wound care themselves, we would of course want to do an education plan, the teaching, reinforce that teaching, and then evaluate our teaching. Some wounds can take months and months and months to heal, so some people do go home with them. And this is the end of part 5 and the end of integumentary.